Hello, Chairman. Thank you. Thank you for inviting us to present our talk. I'm presenting this on behalf of Alison Hainworth, who actually had to return back to the UK. Okay, good. Imaging of the pelvic floor, there's various different methods. One of our newer methods is integrated pelvic floor ultrasound. That's using various different ultrasound scans of the pelvis transvaginally and transperineally to get an overall view of the whole pelvic floor anatomy. We basically have three probes, so transvaginal scans and perineal probes to visualize the whole pelvic floor, and you get images in both sections and in real time. Is there a problem with, why is it not? Okay, hopefully this will work. So the aim was to assess normal anatomy in non-symptomatic females using both the MRI and the ultrasound, and to try and identify the important anatomical points and correlate the two together and see what normal may be. We had 20 asymptomatic females, of which 7 had been Paris and 13 nulliparous, with no urinary or bowel symptoms. They both had the pelvic floor ultrasound scans and an MRI scan, and you can see here what we can assess with each scan. The only thing that you can't assess with the total pelvic floor ultrasound is incomplete evacuation, because we don't use any paste when we're doing the ultrasound. The MRI is performed in a lying flat position, and the pelvic floor ultrasound is performed either in lithotomy or with the legs bent up. The results, interestingly, there were 12 cases with an anatomical abnormality in one or both of the images, and all the patients had intact sphincters and intact levators. You can see a breakdown. There was a mixture of anterior and posterior pathology identified. 8 cases had no abnormality on either imaging, and there were 6 with no posterior compartment imaging and just anterior compartment imaging, and we found there was cystocele present in 8 patients, grading from grade 1 to grade 2. There is discrepancy between the two, but these are small cystoceles, so the difference between grade 1 and grade 2 on imaging we're uncertain of. Enteroceles were more commonly seen, or we found more on the pelvic floor ultrasound. Interception, MRI, because you're lying flat, we don't usually see interception, and we know that from reviewing it with proctography. And obviously rectoceles on both sides we saw, and they're again quite small rectoceles, but still present. There were 6 cases with posterior compartment abnormalities, we said, and this is just a breakdown showing you of what we found there were, on each case. And you can see between the two, most times they correlated, or we found both together. Now, we used the initial imaging to assess what we would classify as significant MRI on ultrasound when comparing it to the MRI. The interesting thing was when one of the tests showed a pathology and the other one didn't, it was a small and non-significant finding. So a grade 1 cystocele or a small rectocele. The bigger, more significant findings were present on both the investigations. Interestingly, there was functional and findings on both, where either there was poor propulsive effort or incomplete evacuation. Obviously seen more on the MRI, and this is possibly because patients lying flat, trying to defecate and trying to bear down. So you will, and we know this, it will show more of what you would think would be functional abnormality. So it's quite cautious that these are 20 normal people with no problems in defecating at all, but a significant number. When you do the imaging, you think actually there is a functional problem. So it's important to take that into account when we're looking at patients with pathology. There was agreement between both the modalities for the various findings. The ultrasound tended to overestimate findings compared to the MRI, which we would slightly expect, because on the ultrasound you're in a slightly more physiological position rather than lying flat. All these patients were asymptomatic, but it is a small group. It's quite hard recruiting more people. Ideally, we would have had a bigger split of nulliparous and parous to see the difference as well. And it's important from this to remember that finding a cystocele, rectocele, enterocele, or poor defecatory technique doesn't mean it's a symptom and a cause of their pelvic floor pathology. We would like to obviously try and recruit more people and do more numbers, but I think that's quite difficult. And we're now looking at those patients with pathology and comparing the two investigations together to see what findings we find and see if it matches. Thank you.
Any questions from audience?
Go on.
I have a question for you. Do you think that this kind of evaluation is a first line, where you see the patient in the first visit and you perform this kind of ultrasound, or is a second level of evaluation?
So we've changed how we manage a lot of these patients now, and they would make sure they have their conservative treatments first before going, and we would use the ultrasound at the moment as our first line for investigating their pelvic floor symptoms, rather going for MRI proctography or the fluoroscopic proctography. One, because it's cheaper, it's easier to do, and we can do it ourselves in outpatients. Yeah. At the moment, our confidence isn't high enough to use it alone. However, what we know from this study and then looking at those with symptoms, there may not be correlation for all of the rectocils, but those that you see on ultrasound pelvic floor imaging are the ones that will be significant on defecating proctography or MRI proctography. So we use it as our first test because it's cheaper and easier. If you don't see anything significant on the pelvic floor ultrasound, you're unlikely to see anything further off. So it's our starter test. As we gain more confidence and we do more of this, it hopefully will replace doing the other tests because it is cheaper and easier and doesn't involve radiation. Lunchtime.
Okay.
Thank you
Thank
very
you.
much.
Thank you very much.